welcome back to blackdoctor.org. And this evening we are having in case you haven't seen, a fibroid series. And I was trying to find the ticker for tonight, but I can't find it. So, we'll try this one. So Fibroids Unveiled. This is the last of the series. We've had three wonderful shows. You can watch them, of course, in perpetuity on our YouTube and on our Facebook. Please share the broadcast because if you are a Black man or woman, inevitably you know somebody who has fibroids. They might not know that's what they have yet, and we will talk about that as well to figure out how you know and what to do. And so we have an amazing physician. He is known as the Fibroid Slayer that is with us this evening, and we have a patient. So we are going to start off with our patient story, but welcome to the show, Margaret, and welcome, Dr. Pierre. So, Margaret, let's start with you. Please explain to us your fibroid journey.
Well, I guess my journey began when I was in middle school. I always had extremely painful cycles, heavy throughout middle school and high school. Went and saw the doctor when I was in high school, and initially was put on birth control pills to try to help to regulate my cycle and to alleviate some of the pain. When I made it to which really didn't help a lot, but that was primarily what I was told, was put on all sorts of hormones, gained a lot of weight, but still was experiencing the same symptoms. Then when I moved to Atlanta after I graduated from university, I I saw a doctor. We went through a couple of different strategies and finally had my first surgery when I was in my 20s. And when I had that surgery, it was determined that I had endometriosis initially with polyps. Then after that, things were better for a little while, and then symptoms returned. And this is when, after I'd moved from the US to the Middle East, and I found a doctor while I was living in Abu Dhabi, and had all sorts of ultrasounds, things of that nature, found out that I had fibroids. And so had another surgery at that point to remove the fibroids, and again was in a space where everything was okay, but then ended up having the next year having to have an additional surgery to remove more fibroids because the first physician was not able to remove all of them. So I saw a different doctor and then had to have an additional surgery to remove the rest of the fibroids. And then after that, I moved to Qatar and saw another doctor because the symptoms came back again. And they saw additional fibroids, and living in my own little state of denial, it's like I do not want to have another surgery because I felt like it was just constant and was consistent, and it wasn't helping because they were continuing to come back. And so at this point, I just said I'll try to find another way to deal with them, trying to look at diet, exercise, things of that nature. And I haven't been back to a doctor, unfortunately, because I just I don't want to hear the same thing again and not hear of another solution or find another way to deal with what seems to be a very habitual problem. And I know many women who are there with me in the Middle East, that are here with friends in the States, who are consistently dealing with the same thing of saying, okay, you have these fibroids, will come in, and it's just repetitive. It kind of goes into this cycle of constantly having to go in and remove or have um, partial or whole hysterectomies to combat the fibroid issue. So
Wow. So how many surgeries was that?
3.
I'm so sorry. So, unfortunately, your story is like many. We do need to introduce Dr. Seedhoff. Is that how you say it?
That's right, CDOF.
Oh, yes. Okay. So, Dr. Seedhoff, you do invasive GYN surgery. Perfect. At Cedars-Sinai.
Minimally invasive. We try to avoid the maximally invasive surgeries if possible.
Well, I'm sure Margaret would totally. Were yours minimally invasive?
Yes.
Okay.
Mhm.
Wonderful. So, I will, first of all, Dr. Pierre, did you have anything to say about poor Margaret?
Um, Margaret's a case that I see all the time, um, and it's really it really kind of burns me to hear her have to go through stuff like that. I will tell you that you do have answers, Margaret. I guarantee you've been told a lot of misinformation, and I can guarantee you that you've had surgeries that were not performed appropriately, which is the reason why this is reoccurring for you. But there are answers for you. I will say that. I'm sure we'll dig into her case a little bit more, but I'm definitely very very opinionated and unapologetic about being opinionated about um, treatment for fibroids, especially for Black women, and how you have options and you have um, things that are available to you that have not been told to you. I'm very happy to have the conversation.
So, what strategies can be implemented to improve patient provider communication and trust, specifically for Black women seeking treatment for fibroids? Either of you can take that.
I mean, for me, first and foremost, patients need to be heard. You need to be able to talk about your experiences. You need to talk about your family. You need to talk about every misconception that you have and everything that you've heard. Number two, there needs to be a very, very clear transparency about um, what has happened in our country for centuries to Black women, and how that has impacted medical care all over, and how it's impacted the mentality of our Black women as they approach medical care, for especially for gynecologic issues. And then we need to talk about all options. And what I see a lot is that, as physicians, we are talking at our patients, and this is not a mutualistic relationship. It needs to be one where we not only talk about it, but I give you all of the tools that you need to make an informed decision about your own health. Because at the end of the day, you have options. You should be able to hear all of those options in their entirety, ask questions, have complete understanding, and then you make the decision that makes sense for your life. Because I have all too many times, like I have women flying in from all over the country because they've been told by multitudes of gynecologists that they had to have a hysterectomy, or that it was pointless for them to even try to preserve their uterus, or it couldn't be preserved. I've heard that, countless numbers of time, and it's really a travesty. So, for me, that I start off with just a conversation, and allowing my patients to be able to talk, vent, and talk about everything. And then we dive into, all of the options and what makes sense. No exams the first time I even see someone. It's a conversation first, so we can get everything all out in the open and be able to have a very, open conversation and build trust. We have to build trust. And I think that's the biggest thing too, is like, our patients don't trust us, because we're not listening and we're not allowing them to be active participants in their care. So that's my approach personally. I can talk about it all day, but that's how I approach it.
Dr. Seedoff, do you have anything to add?
Oh, for sure. I think that trust element is really important, and there's good reason why there's not a lot of trust there. I think we've failed women in this area and a lot of other areas, but especially for Black women, the evidence is really clear that there are disparities out there in terms of the care that people have access to. And so I absolutely agree that we have to do a lot of work up front, try to rebuilding that trust. And so much of that, I agree, is listening to what's important to that individual person, because that differs from person to person. I think, a lot of times assumptions are being made. Maybe because somebody is in her 40s, it's assumed that she's not planning on having additional children, or that fertility is the only reason that somebody might want to preserve her uterus, and that's not necessarily the case. And so, I think we really do have to do a good job listening, and then really being honest about our impression and what are likely outcomes based on the treatments that we recommend. We definitely see a lot of people that are recommended treatments that aren't ultimately going to give the outcome that we want. Sometimes people aren't good candidates for some of these alternative procedures like radiofrequency ablation and then uterine artery embolization. I mean, those have their role for sure, but not everybody's a good candidate. And so just sort of putting those out there and subjecting people to sort of unnecessary procedures that aren't going to get them to where they need to be, that doesn't serve people well either. So I think, developing that trust and really being authentic and genuine about, what the advantages and disadvantages are, and applying that to that individual person that's sitting there in front of you, I think are the most important things.
And how can healthcare systems and institutions address the racial disparities in surgical interventions for fibroids, such as the over-reliance on hysterectomies among Black women? Either of you?
First and foremost, putting an emphasis of importance on having representation and equal representation in medicine is how we start, and then also having some very structured discussions, as well as some cultural competency discussions amongst providers about the truth about what's happening, and some education is going on. I mean, there's a lot of miseducation amongst us as physicians that we did not get in medical school, did not get in residency, and are now left on our own auspices to try to figure it out. We can't, necessarily fault anyone for their upbringing or where they came from, but we can fault people for not trying to seek more knowledge about the patients that they're caring for. So I think that is extremely important as we, try to tackle inequities and eradicate healthcare bias, because just going along and continuing the status quo is clearly not working. I mean, we have less Black doctors now than we did 50 years ago, and that's a testament of where we're at as a country. So we have to be very truthful and honest where we're at. But at the same time, we also have to keep on the forefront that we have patients that we're caring for, whether the social things that we have that are happening, but these patients still have to be cared for. And we can do something in the immediate about that now through education and communication.
What, and Dr. Sidon?
Yeah, I mean, it's certainly something they care about at our institution as well. We published a paper this year out of my division specifically on looking at disparities in fibroid treatments based on race, and found that it was, we're just as guilty as everywhere else. And part of that, I think, is being able to get people into the right hands. You really want to have somebody who's experienced with dealing with the nuances of complicated fibroids and does this all the time, and it really is able to offer the full range of options when it comes to this. And then just other things in general that we're doing in our department. We have a JEDI series that goes throughout our academic year, teaching the department, our providers, about issues related to justice, equity, diversity, and inclusion. And a lot of these things come up, and I think it's helpful to hear different perspectives on this and to really engage with what's out there in the literature and just have open and honest conversations about this with one another.
Definitely. And actually, this is kind of going backwards, but what are the current challenges and disparities in assessing equitable treatment and care for Black women diagnosed with fibroids?
You said the current challenges
Yeah.
amongst providers or amongst just period.
Yeah.
Access to quality providers. And I kid you not, I mean, I've used social media as a platform to create awareness and education, for our women. And through that, I've been able to connect with, women all over the country, right? So women from all over the country seeking this consultation.
Uh-oh. Okay. I don't know what happened. Go ahead. Oh,
Advice
there
and
he is.
advice and consultation, from me. And I can't tell you again how many times I've heard women tell me that after 5, 6, 7 doctors that they finally came to me and have been told either they had to have a vertical incision for a procedure, which is completely crazy, and or they had to were forced to hysterectomy, and they had absolutely no other alternative but hysterectomy. I hear this all over the place, and it's just to not have those providers in these places where all of these women are at is no wonder, why we have just the mistrust and the mistreatment of women. So I think access to quality healthcare. And we're talking about women with great insurance. We're talking about women with great jobs. We're not even. It's not even a economic issue, a socioeconomic issue. You're talking about educated women that
Right.
have complete access to go to whoever they want to, cannot find quality care. And to have somebody, fulfill the things that they want to happen as far as have so that they want for their lives as far as fertility is concerned, they can't find these providers in their area. I think that's the biggest barrier, and we have to be honest about it. Have to be very honest about it.
Margaret, what could have been done to make your experience better?
I think a large part of it has to go back to feeling heard. Um, Anytime, especially when I was younger, when I was in high school and missing school and dealing with a lot of the issues that I had to throughout um, my younger years, I felt like nobody really believed that I was experiencing what I was experiencing, that I was in the type of pain that I was in, that how uncomfortable and how difficult it was every month for me to deal with this. And so even with having conversations with doctors and nurse practitioners, even as I got older, it was just kind of like, well, no, it can't be this because this is really only what happens, or it really can't be that bad. I think maybe you feel like you're exaggerating, or that and it's difficult, especially in the situation that I was in, because I did have a job, and I did have insurance that was provided for me, but it was an expensive venture to try to find somebody who would even pretend to listen to me, because it's like you kind of come in, you sit down, you start talking, and then you're interrupted, and they kind of just have another conversation, and you're trying to say, well, no, and then you end up leaving not having discussed some of the things that you wanted to, because of the amount of time that they're allowed to be in the room with you, or just not feeling as if the physician is believing that what you're saying is accurate.
Yeah, it really, I've always said it comes down to listening. We've got to listen to the patients because they know better than anyone. And if you listen, you can really get a lot of information. That's what the H and P, that's the H, the history. They know their history better than anyone else. And then, of course, we have that horrible myth about Black women can take much more pain than others. And
Mhm.
so, we are not really in a lot of pain, but I mean,
I was even told that in the hospital after my first surgery, when I was in recovery and the woman next to me was getting pain medication, and I asked, I was just like, "Do I receive the same?" And she was just like, "No, your threshold for pain." Um, she said that my threshold was higher.
oh my God.
Don't even get me started on that. My whole thing
So
about
I
that.
was
I'm
like,
about to give a
"Oh,
lecture. I'm about to give a lecture to my residents about this and this ERAS protocol and a bunch of other misconceptions and things that we have, and don't take, Black women and into consideration. This is really, and we're not honest about things. Like there are studies now that show, that residents, medical students, they view Black women's pain and their perception of like pain differently, right? They think that they're, easier blood draws, and and they don't need pain. You just, Tylenol, gabapentin can fix everything. It's not true. It's horrific what's happening. Um, but yeah, I digress. No, but I definitely think that that's a whole nother thing that needs to be addressed, that we don't.
Yeah, that's crazy. I met a lady just this weekend that said that she was only healthy 7 days out of the month.
I hear it all the time.
Margaret, I think you mentioned that endometriosis was diagnosed for you as well. Is that right? Yeah, that's, I mean, I think another, condition sort of unrelated to fibroids, but pretty common. 1 in 10 women have it. And pain symptoms are often written off, and people are sort of made to feel like that isn't taken seriously. And I think it's underdiagnosed. And, we have this conception that endometriosis is much more common in Caucasian women than it is for Black women. But now we're starting to question, is that really the case? Or we were just underdiagnosing it because we weren't paying attention to fertility concerns or pain, or offering people the surgery that's needed to diagnose it in many cases. So I'm sorry you had to go undergo that as well.
That's terrible. Yeah, that pain thing, that is crazy. Are there any innovative approaches or interventions that have been successful in addressing the disparities in fibroid treatment outcomes among Black women? I know Dr. Johnson is very well versed in this, so I don't know if Dr. Seedoff as well, but
Well, I think one thing that's emerged in the literature is access to a high volume provider. And, my world is in minimally invasive surgery. So, for large and numerous fibroids, oftentimes, big open incision is the only thing that's offered. And sometimes that's absolutely the right surgery to be done for, removing fibroids where you're sparing the uterus. But many times other things can be done, and we can do these with much smaller incisions that are associated with a much shorter recovery and less pain, smaller and faster return to normal activities, et cetera. And so it seems to be that the disparities are somewhat mitigated by being able to get somebody into the hands of experienced provider that has knowledge of these alternative techniques.
Dr. Pierre, did you have something else?
Yeah, I mean, there's many things that I feel that I think that just really need to be discussed as far as like surgery. I mean, I'm a minimally invasive specialist as well, and I proctor for like Da Vinci robotic surgery as well as excessive all over the country. Um, and from a minimally invasive surgeon, I stopped performing robotic myomectomies about 5 or 6 years ago. And every myomectomy I perform is through a low transverse incision that's in the hairline, and I've removed 13 and a half pounds of fibroid, and preserved the uterus in a low transverse incision. And the reason why I stopped performing robotic myomectomies is because the key to fibroid surgery, and what I've discovered is that you have to eliminate every fibroid. Anything that looks like a fibroid, it has to be eliminated. You have to get it. Today, had a surgery on a lady that I performed Accessa on about 3 years ago, but her fibroids were too numerous. Like she had, I removed like over 65 fibroids today, right? So, yeah, today. And it's, for her, like this is she chose that minimally invasive approach, but she needed a myomectomy. And when we perform these robotic and the laparoscopic myomectomies, and I was listening to Margaret talk, and I already know what happened. We performed a laparoscopic or a minimally invasive myomectomy, and they left fibroids back. So when we look at these studies of myomectomies, what we're doing is it's not just looking at particular physicians that are removing all of the fibroids, because not many do. We're looking at every fibroid surgery. So people that go in and they'll remove just the ones that look problematic. People that go in and are doing them laparoscopically, whatever, and you're putting all of these in, and now we're looking at the recurrence rate from all of these different approaches to them. Whereas personally, any patient where I perform these myomectomies, where I focus on removing every single speck of fibroid tissue that she has, are not returning, right? And that's 5 years worth of personal data. Now, mind you, it took me 5 hours today to get all of these fibroids back, but I struggled so she doesn't have to struggle. I struggled so she could preserve her fertility and do the things that she wanted to do in life. So that's the sacrifice that I make. But if we're honest about, just the thought of laparoscopic approach to myomectomies, um, it really doesn't make complete sense, because one, again, the success to fibroid surgery is removing all the fibroids, and then number two, these patients have to have a C-section at the end of the day anyway. So we're going to do laparoscopic or robotic myomectomies, not get the fibroids, and then have to go and turn around and do a C-section. In addition, we need to change that approach. Again, too, no patient should ever get a vertical incision. I've never performed a vertical incision on any patient for a myomectomy, and we're talking 36, 38, 40-week gestation. It doesn't matter. It should not have a vertical incision. And then even with that, going back to, the minimally invasive approach, I've never performed an open hysterectomy. Every hysterectomy I've ever performed over the past decade has been robotic or laparoscopic straight stick. So it's just the approach. But when it comes to myomectomies in of themselves, Margaret, to the point that I'm making to you, is that if we're to be serious about your fibroid issues and fibroid diseases, eradicating and treating your entire spectrum of fibroids. And that will be my advice to you. And that's my advice to every patient. It's like, if we're going to do it and we're going to preserve your fertility and we're going to go in and we're going to deal with these fibroids, let's deal with it all. Like, because otherwise they will, a 3 millimeter fibroid, 4 millimeter fibroid can very easily come back and be a 10, 11 centimeter fibroid if you just leave it there. So you have to get all of the disease to really be effective. That's my 2 cents.
Margaret, you ever heard anything like this? So, but
can I push back just a little bit
on
that and agree that I think it's really important that we treat these fibroids completely, but a lot of that is preoperative planning. So getting the right imaging modality, it's pretty clear that for fibroids, ultrasound's insufficient in most cases. So we need to get an MRI on these and be able to establish whether or not laparoscopy is going to be feasible to get all of them. Because I think if somebody's a poor candidate for a laparoscopic myomectomy, you do run the risk of recurrence. And so anyway, I think there are a lot of benefits to laparoscopic myomectomy, and they do vast majority of them that way. But you absolutely have to be a good candidate for that. And you don't want to do exactly what Dr. Johnson's saying, is go in and leave fibroids behind.
So Margaret, how did you deal with the mental anxiety and depression as a result of the medical issues and treatment?
Well, I guess I'm still in this space where I'm operating in denial, because it's just like, okay, well, I'm not hearing what I want to hear. I'm not comfortable with the people that I've been dealing with, so I just don't, which is not the best approach. So I am in the process of trying to figure out the direction I want to go to, because I told you the last time I went in for imaging, they found um, more fibroids, because, like you all said, they did. I know that after the second surgery, I was told that they weren't able to get everything, um, and then the third surgery, she said that she got most of it. So I guess I'm assuming that that there was some left. And so now I'm back in the situation where they are seeing them again, but I was just like, I don't I don't want to go through the same process again. And so it is frustrating. And I know that I'm putting my health at risk by not dealing with things appropriately. And so I do need to find another approach. It's just trying to find the best way to do so. So it is frustrating. And and it's not something that I really talk about a lot. You know, you don't really talk to people about it. I mean, I know that people are dealing with it and experiencing it, and I hear girlfriends talking about, you know, the surgeries and the procedures that they're having. And you know, you do your research. It's just difficult to find something that, with me as an educator, I don't really know what actually works and what doesn't, what would be best for me. And the medical professionals that I have been dealing with haven't been able to give me solutions that have been working. And so it does lead to a form of mistrust. And then you just don't talk about it, because it's like you're not getting the response that you were hoping to receive. And so I'm just like, well, you know, I'm getting older. Eventually, something will, you know, something will pass and we'll be okay. So who knows? But yes, it is frustrating, and
I'm
it's
sure.
upsetting, and you don't feel like it should be something that you should be dealing with in 2023. The same thing that I was dealing with in the 90s, I shouldn't still be dealing with it 30 years later.
Right,
Mhm.
right. What role can patient advocacy groups and community organizations play in promoting equitable treatment and care for Black women diagnosed with fibroids? Clearly, you haven't found any of these groups.
No.
Okay.
Education is so key there, making sure people understand what the right issues are, asking their doctors, are they getting the right information? Are they being offered all the available treatments? You know, are they experienced in dealing with um, all the different aspects of fibroid treatment? It's a really important part of community outreach. Yeah, for
Yeah,
sure. They're
definitely.
going to listen to you a lot more than they're going to listen to me, Margaret.
Yeah, I think that those groups can be very helpful, because one, that could be a place where they're sharing information about great doctors. Even if it's a Facebook group and you have to travel, like Dr. Johnson said, you know, people come from everywhere. So, you know, if it's something like that, even, you know, I think that they probably can be very, very helpful to advocate and promote what needs to be done and what needs to change. Because if the patients won't go to the hospital, then the hospital can't make their money. So, you know, that could be very helpful. How can healthcare providers ensure that the decision-making process regarding treatment options for fibroids is shared and informed, empowering Black women to make choices that align with their values and preferences? That goes back to those advocacy groups too, but where else do you think?
You know, it starts with the consultation or the visit. You know, patients have to feel, it's a feeling they have to have. Like, you know, when you're being heard, or when you feel, or when you have options, or when you, like you're being forced into something. You know that. I mean, that's a palpable feeling. You know, that's where it starts. And I would, you know, tell patients or tell women, period, just like, you know, if you don't feel you're being heard, if you don't feel comfortable when you leave, you keep looking until you find somebody that makes you feel comfortable. It's not a lot out there, but there are people that exist, and don't settle. You know, don't settle. You know, for just whatever your region is or whatever, your immediate provider group is, like, be able to reach out, like talk. Social media is a wonderful place, right? It allows you to be able to, reach and touch people that, we wouldn't have been able to do, 30, 40 years ago, but now you have people that have had surgery, that have providers that they trust, that have, networks and forums and things that are great sources of, or resources for you. So, utilize it as much as possible.
Yeah, he's right. Social media is a wonder when used properly is a great tool. But it definitely need to get the word out and keep spreading it and keep spreading it so that people understand. There's so many things. I remember many years ago when it was all about the uterine ablation, and everyone was like, they were coming to me and Renee, da, 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 and I was like, but I think there's something else. My friend has told me about another procedure. I think you need to find another doctor to talk to them about that. And because then they would ask their doctors about it, their doctors said, well, they weren't a candidate for that. And I was like, well, you should figure out something else. And I had several people in their 30s talking about they had to get hysterectomies because of fibroids. And I said, wait. You need to find a different doctor. Let me find you a doctor to talk to, because you need to get a second, sometimes a third, sometimes a fourth opinion to just be certain that you've covered the gamut. And, you need to find one of these wonderful minimally invasive surgeons, like Dr. Seedoff or Dr. Johnson, who is not trying to cut you open and, take away your fertility, but even more importantly is, throwing you into menopause possibly, right? At 30 something years old. That can be a lot to deal with physically, but mentally too. So, yeah.
It doesn't have a vested interest in what the outcome is going to be. What's right for you is not going to be right for everybody else, and we need to come to that with an open mind. And our ego isn't in it. Anybody who's threatened by the idea of somebody else getting a second opinion is probably not the doctor for you. There's absolutely nothing wrong with getting that second and third opinion, for sure, and going with the person that you feel the most connection with. I mean, I think that's half of the process, is feeling comfortable with the providers treating you, if it be surgery or anything else.
Yeah, my friend she had surgery, and she said his bedside manner was awful, but he really knew his stuff. And she was like, I trusted him, and everything came out great.
Well,
he just didn't have good bedside manner, but he was really he was a good surgeon. So.
Yeah,
fair enough.
Try
to have both.
Like, yeah, to get both. Like she but yeah, get second, third, fourth opinions, and I echo Dr. Stickles' sentiments. You has
You're breaking up and you're frozen. I don't know what's going on with the signal.
Can you hear me? Can you hear
Kind of.
me?
Now we can.
A little bit.
Now we can.
So I was saying that your provider I never have any problems with my patients getting different opinions. You should get all the opinions you possibly can until you feel comfortable. Yeah, second, third, fourth, fifth, sixth opinion. Make a comment to care.
What steps can be taken to increase diversity and cultural competence within the healthcare workforce, specifically in specialties related to fibroid treatment, to better meet the needs of Black women? So I would say first and foremost, somebody needs to be on the board from the admissions department at the school. Let's start there.
But you just had a Supreme Court justice. I
was just going to say exactly that. We need to fight against that and find ways around it so we can continue to have equity in our admissions.
We're going backwards. So we could talk about that.
Right.
We have to as a people. As a people, we have to start making more stances, and we have to, start coming together and starting to make, our opinions not just heard but felt, right?
Mm-hmm.
Civil rights, they made moves like that. That was the time period in which movements were made more than any time in history. Why? Because they galvanized, they boycotted, they did
Yep.
all types of stuff to make an impact on the bottom line. They made an impact on the dollar. They made an impact on other people's livelihoods. So you had to listen to them. Where if we don't do that now, the status quo keeps coming, and it gets even worse. Take affirmative action. That's the first of the domino. It's more that's going to come eventually. So I mean, we could talk about that all day long. That's a huge topic.
Yeah, it's insane. But
It's our
Much so.
responsibility. We created this system that is
Correct.
set up as inequitable, and so we've got a lot more to declaring. Victory that we're beyond race in these issues is just being short-sighted. We
right.
need to do the work to keep getting us back to where we should be.
But I have a question. But you said Cedar Sinai did studies and figured out that they were, doing exactly what they said, what everyone has been happening to Black women. Have you guys gotten some sort of task force together to figure out how to address that?
Yeah, I mean, we have, and I mentioned that Jedi initiative, and I think
Yeah.
that's probably the biggest thing we're doing as a department, but also just having honest conversations about this and trying to improve those pathways to referral to specialists that can really, because we didn't see those same disparities among the people that do in our high volume surgeons. So that's one way we can combat it.
Okay.
Well, I wanted to, I'm going to take care of the easy stuff first. So first, I want to thank our partners at Cedar Sinai and Dr. Cedar for joining us again. Dr. Johnson, thank you for coming in, brother. Anytime you want to come back, you're welcome here. And we talk about a myriad of topics, and your site was mentioned on one of the earlier
I
shows.
told him.
Oh yeah, Fibroid Slayers, get it. I'm like, oh, we got a Fibroid Slayer right here. I didn't realize that was you. So I appreciate you coming on and standing in the gap for Black women and for a Black man to do that really in this space is phenomenal. And I'm going to be a little bit transparent. Margaret is my sister, and
Oh.
that's why I took care of the easy stuff first. To know she had to go through that.
It's a lot, man. It's a lot.
But I'm going to make this point for people, and that's why we're doing this show. That's why we put together this series, is because we're not talking about it enough.
Mm-hmm.
I didn't learn about her struggle with fibroids until we did a show a couple of months ago about fibroids. And she sent me a text message and said, oh, I could have been on the show. And it was really innocuous, but it landed so heavy on me that said, why didn't I? And so I went through all of the stuff that you go through. Like, am I being so selfish that I'm not paying attention to what's going on in the lives of my family? Are we not having real conversations about health as a family and as a people? And so we've got to do better as a people about this. And so conversations that are impacting depends on where you're getting the research. 70 to 80% of Black women, we've got to have these conversations. And I'm not going to be dependent on mainstream healthcare to have these conversations. We have a wonderful platform here at blackdoctor.org. We've got great partners in healthcare like Cedar Sinai that are willing to step up. And Dr. Seedoff did the previous show, and I asked him to come back, and he said yes. And so we need partners like that. We need partners like Dr. Johnson. I know Dr. Renee Hooked it. Hey, we need you on this show. And the fact that you're willing to give up the time after doing surgery today shows a commitment that you have to this topic. My sister is a delegate at her Delta conference right now. I'm going to lay it all out there. We're being transparent. And I asked her to do this, and she's here sharing her story to the world about what's going on. And that those are the types of things that move this conversation forward in a way that is both meaningful and impactful on people's lives. And so um, I'm happy we put together this series. I plan to do it every July. And we're going to have these conversations not just in July, but throughout the year, because it is so important and so impactful to give women not only options, but a place to be heard, uh, and encouragement on really having those conversations and getting that second opinion to save whatever dignity, whatever they want to save in their lives. Everybody's situation is different. But if we're not talking about it, if we're continuing to have surgeries that are ineffective, and I'll say that because if you have to have three, something is ineffective in what was
Yeah.
happening before. I'll say that out loud. And so we've got to do a better job. And so I want to thank everybody for being on here. I'm sorry for getting emotional.
No
But
apologies needed.
None at all. Hey, Margaret, holler at me offline. I'll help. Like, let me know. Like, let's talk.
Yeah, I was gonna tell you. I'll just wait until when we log off. But
Yeah, absolutely. Yeah,
is
we'll
there
talk.
any last minute? First of all, you know what we didn't say? I want people to understand what can fibroids do to your body if you have fibroids, because I think a lot of people hear it so much, kind of like diabetes. Oh, he just has a little sugar. No, fibroids are serious, especially when they are numerous and large. So, can somebody just really quickly just give us a few things so that everyone will understand the actual importance of why it's so important to address this?
I mean, I could say real
Yeah.
quickly that, you know, one thing I will like to dispel is that fibroids can impact us significantly, but fibroids also can just be there and we can still live quality lives, right? So if you hear the word fibroid, uh, don't be alarmed right away, because just because you have fibroids does not mean you need surgery or you need treatment. Fibroids can cause things such as infertility, dysmenorrhea, which is pain with your bleeding, or pain with your cycles, abnormal uterine bleeding, meaning you bleed excessively or you bleed more than you're supposed to in shorter intervals, pain with sex, right? Increased frequency of urination. Right, these are some of the things. So pelvic pressure, even large, very large fibroids can cause things like hydronephrosis when they pinch upon the ureters, or they can cause significant constipation. But that's really significant size fibroids. Overwhelming majority of women with fibroids don't have symptoms that severe. They have them where the pain with intercourse, the bleeding, dysphoria, um, pain with your cycles, cramping, infertility, frequency of urination. These are the symptoms, the buzzwords that you should be looking for. And if they're impacting you, that's when you need to seek treatment for them, and seek out a doctor, because it could be fibroids that are impacting it. But it also could be, right? We also, the misconception is that if you have abnormal bleeding, or if you have abnormal periods and you have fibroids, that they're synonymous, that it has to be the fibroids that are causing that problem. That's not always the case, because all fibroids are not built the same. Fibroids are significant for two different reasons: size and location. Right, you can have very large fibroids but are not problematic. I have women walking around right now with 11, 12, 13, 14 centimeter fibroids with absolutely no symptoms whatsoever, as opposed to a woman that has a 1 or 2 centimeter fibroid that's pushing into the cavity of the uterus, that will be having all the symptoms in the world. So being able to have a very transparent discussion with your doctor, who can explain what's going on with your body, are the fibroids really impacting you, and what those treatments options, how they will can expect to impact the symptoms that you're presenting with from the fibroids. But yeah, having that conversation is extremely important, and having somebody knowledgeable about fibroids to give you options that make sense for you. That's it.
Yeah, and knows to monitor them over time, because if they maybe aren't bothering you right now but continue to grow, that's a time when you start to think about maybe intervening. They can even do things like put pressure on blood vessels that supply blood back to the lungs from the lower extremities, and you can get a blood clot, and that can be really tricky to treat in patients who have really large fibroids. You need to put them on blood thinners to treat a blood clot. Well, that can exacerbate the bleeding associated with fibroids. So you definitely want to keep an eye on it. And, sometimes people get told, oh, don't worry, your gigantic fibroids aren't going to cause a problem anymore after menopause. Well, that's not always the case. If they start out really big, they may shrink some in menopause, but may not be enough to get rid of some of these symptoms. So, yeah, for sure, they can have some serious health risks.
Yeah, just one thing I learned about fibroids as a lay person is that when they're growing, especially the larger ones, they're pulling blood from you got so much blood, and if they're pulling blood from the other areas of your body, that can't be a good thing, right? So I'm just going to say it in layman's terms. That can't be a good thing. Also, so just thinking about it from that perspective, we have to recognize it's important, and so many people are dealing with it. So Black women, in particular, women in general that get fibroids, with Black women in particular, there are some things that we have to do, that we can do when we're not seeing Dr. Johnson or Dr. Seedoff, and that is make sure we're exercising. We got to move. We've got to eat right. There are some foods that the American diet is in general terrible. Let's just call it what it is. And so you're going to have to swim upstream a little bit. Once you get into that groove, it'll be easier. So don't think that when we say diet change, that we're just going to leave you there. And I said on one of the previous programs, and I'm saying it on this program, we're going to put together a series on how to change your diet effectively, right? So it's not like we're going to tell you something to do and not help you do that. So we're going to walk you through that process of making that diet change. And it's not a dramatic, you don't have to do this some people did the cold turkey. That works for some people. But for most of us, if you're being honest with yourself, cold turkey does not work. And so what we're going to do is give you the steps on how to we're going to go from A to B, not to A to Z. And then once we get comfortable at B, then we're going to go to C. We're going to get you to Z, and it's going to be on your timetable, and we're going to give you the steps on how to do that. So those two things are very important. Reduce stress in your life, right? Stress can cause all types of things, releases cortisol, and all the things that happen in our body when we're stressed. And we know, as Dr. Johnson said earlier, the environment in this country right now stress is increasing, particularly in people of color. I'm just going to say that across the board. Particularly in people of color, stress is increasing. And so we have to find outlets. And one of those things could be just turning this off and walking away, right? Taking a walk, leaning into those things that you really enjoy, friends, family, music, dancing. Get away from what's happening in society, because it can drive you nuts. Stay informed, stay vigilant, and I'm going to say a dirty word, stay woke, but you need your break. Your brain and your body needs a break. Take a break when you can, and get a sufficient amount of sleep. So those things right there, we use an acronym: eat, move, think. That's your stress. Sleep, EMTS. Those 4 things right there can go a long way towards improving your overall health and impacting your fibroid journey.
Definitely. Well, thank you very much, gentlemen. And Margaret, thank you so much for sharing your story, because I know that your story is like many people's stories. So I'm sure that you sharing was helpful to somebody. And we've already received lots of positive feedback that people learned something today. So Dr. Seedoff, how can people get in touch with you?
Probably the easiest way is just a quick Google search on Cedars-Sinai and invasive GYN surgery. I'll just ask to for a moment of gratitude. I'm very obviously not a Black doctor, so being willing to invite me into this space, I take that with a lot of humility. And obviously I don't experience this as through a really personal way. So I try to keep, an open mind and open ears as much as possible. And, I really appreciate the opportunity to be in this space with you all.
The fact that you're here says a lot though. Like that's step one. It's not many that will be on something like this. Like, so that says all that needs to be said, honestly, for me.
Definitely. And how can we find you?
For me, so that's the website, fibroidslayer.com. And all my like IG is Dr. P, spell out Dr. DOCTORP 23 on IG, Pierre Johnson MD on Facebook. Highly accessible. My aim is to eradicate healthcare disparities through education. So, I have, a consult service where I basically, I will listen to anybody wherever you're at, over the country or over the world. I have women that have called me from the UK, from Europe, from Ghana, from Canada, through social media. So I've been able to utilize social media to start the plight of eradicating healthcare disparities, especially for women of color. I'm accessible. Like I said, Margaret, I am here for you, open ears, to try to help you get through it, because my heart goes out to you. Like, I hear it all the time, and I want to do everything possible to help as many women that I can while I can. So yeah, that's me.
Thank you so much. And everyone, we'll see you next time at blackdoctor.org. Good night.
Awesome. Thank you guys for having me.
Thank you.